about electrolytes, but that is the normal physiology, okay? So in this water and electrolyte imbalance, so our learning outcome is to cover both hypo and hypernatremia, both hypo and hyperkalemia. So in these four conditions, you need to know the causes. What is the cause of hypo or hypernatremia? What is the pathophysiology behind each of these causes and the effect to the body, as well as these two diseases you need to know in detail, which is the syndrome of inappropriate antidiuretic, as well as diabetes insipidus. And you need to also be able to interpret laboratory findings for the diagnosis of SIADH and DI. Okay. So water. So water ni is air lah kan. So our body is made up of water. So 60% of our body weights are water. So if let's say you are 70 kilo, 60% of that are water. Okay. From this 70%, 2/3 are in the cell. Selebihnya, the other 1/3 is outside the cell, extracellular. So from this extracellular, 80% in the interstitial, while 20% in the plasma. So in our discussion today, we will be talking about more in the plasma. Okay? So all this, your sodium measurement, your potassium, your concentration will all be measured in the plasma ataupun urine ataupun serum. Okay? So next is concentration. Yang ni kita ingat baliklah zaman chemistry dulu. So in this concentration, we will be talking about osmolality and tonicity. Apa beza dua ni? Both of them are concentrations, but one of them, osmolality, is the total number of particles. Dicampurlah semua concentration ni, maksudnya kepekatan. The sodium, potassium, glucose, urea, but for tonicity is the particles that exerts the osmotic effect. Ingat kan, hypotonic, saline, hypotonic. So what is the effect of cells in hypertonic solution? What is the effect of the cell in hypotonic solution? Tapi measurement kita banyak osmolality. Okay? So how our body responds to the changes in the water and electrolytes. So kita ada dua. Changes in water balance ada dua. We detect the concentration, or we detect the pressure. So kalau concentration, changes in the concentration, changes in osmolality will be detected by osmoreceptors, while changes in the volume ataupun in the pressure will be detected by photoreceptors. Ini in physiology kan. Okay. So what happened is, the two response is you can either increases your thirst ataupun increases the secretion of antidiuretic hormones. So ADH tu secret daripada mana?
Adrenal gland.
Ada?
Pituitary gland.
Itu kuat sikit. Posterior pituitary. Okay. So water imbalance. Okay. You can have either excess water ataupun depletion of water. Meaning water in excess tu banyaklah water. Water depletion ni means you lost a lot of water. Okay. So in water excess, water excess, you have a lot of water inside your body. So what happened is, this water, you have 60% of total body water, tapi you add another water lagi. Okay, so water ni pergi mana? So dia akan menyebabkan outside surrounding is very hypotonic, kan? So dia akan goes into the cells. So cells akan swell. Okay, all the symptoms you get when the cells swell. You akan dapat CNS manifestation, cerebral edema. So what happened is, you get behavioral disturbance. You can get confusion, headache, convulsion. Convulsion tu maksudnya fitting lah. Coma, muscle twitching, extensive plantar response. So what is the cause of water excess? You can either increase intake, minum, ataupun you reduce excretion. You kurang passing out water. Okay. For increased intake, the number one is compulsive water drinking ataupun nama medical dia psychogenic polydipsia. So you minum air. Okay. Ataupun excessive parenteral fluid administration. Maksudnya at hospital, doktor prescribe a lot of fluids. So patient akan jadi fluid overload. Ataupun ada patient undergoes bladder irrigation. For example, tiba-tiba dia ada hematuria which needs bladder irrigation. During bladder irrigation, large amount of water are given through masuk dalam catheter, masuk dalam bladder lah. But this water will be absorbed by the body. So, it will be excessive water. While in decreased excretion, in patient with chronic kidney disease, where the kidney unable to excrete the urine, so patient can get excess water. Or in cortisol deficiency. So do you remember cortisol secreted by
Adrenal gland.
adrenal gland? So what is the function of cortisol?
Stress.
Stress. Lain daripada tu, cortisol also have mineralocorticoid activities. So maksudnya dia reabsorb sodium, dia buangkan potassium. So in case of cortisol deficiency, sodium is unable to be reabsorbed. Bila sodium tak boleh reabsorb, dia akan keluar dalam urine. Dan water akan follow sodium. So you can have water loss, less excretion of water. And inappropriate or ectopic secretion of antidiuretic hormones. So what is the example, what is the action of ADH just now? Antidiuretics, meaning it doesn't allow you to it reabsorb water, right? ADH, right? So if in excess secretion of ADH, you get water retention. Okay. So what is SIADH? Okay. SIADH occur when there is unsuppressed release of ADH from the pituitary. Maksudnya banyaklah pituitary ni menghasilkan ADH ataupun continuous action of ADH on the receptors. ADH ni dia ada receptors dekat kidney. So kat situ tu action dia continuous sahaja. So menyebabkan water being retained, reabsorb lah kan. So this is ADH. So ADH ni fungsi dia untuk membuka aquaporins. So water daripada dalam tubule tu will be reabsorbed into the system. Okay. So what happened during SIADH? So you reabsorb water kan. Excess ADH, body will retain more water. So kita akan dapat excess volume. Betul? Okay. Excess volume akan inhibit kita punya renin, angiotensin, aldosterone. So RAAS akan being inhibited. Ingat tak? So bila RAAS being inhibited, aldosterone will be low. So aldosterone fungsi dia adalah untuk sodium reabsorption. So sodium will not be reabsorbed. So patient akan dapat natriuresis, iaitu sodium in the urine, as well as water pun akan keluar sikit. That is why although SIADH you ada water overload, patient akan dapat euvolemia. Euvolemia bermaksud kita tak akan nampak signs and symptoms of overload. Sebab water tu akan keluar sikit dalam urine. Faham ke? Okay. Kalau tak faham tanya Okay. So sama macam tadi, bila SIADH, increased level of ADH akan menyebabkan increased renal tubular permeability to water. So water being reabsorbed, this will increase the blood volume and increases the serum hypoosmolality. So serum akan jadi low concentration. Okay. This can cause dilutional hyponatremia. Okay, contoh you buat air sirap, you tambah lagi air. Of course, air sirap tu akan jadi tawar. Okay, so this will inhibit the RAAS. Aldosterone akan reduce, then sodium will be less reabsorbed. And sodium will be passed into the urine, akan ada natriuresis and diuresis. Okay. So what are the conditions that are associated with SIADH ataupun what are the causes of SIADH? It can be due to ectopic ADH secretion in cases of bronchial carcinoma ataupun inappropriate secretion. Maksudnya dia keluarlah in other diseases such as in pulmonary disease, for example pneumonia, tuberculosis, any cerebral disease, head injury or any pain, or if the patient is on any drugs such as carbamazepine. Okay. So the laboratory diagnosis. Just now you remember SIADH is antidiuretic, meaning body is full of water. So the serum sodium will be low, hyponatremia, because air sirap tadi dia dah jadi diluted kan. Serum osmolality, the kepekatan will be low, hypoosmolar. The urine osmolality will be high because water being reabsorbed daripada tubule. So urine yang keluar akan jadi very concentrated. Okay. Urine sodium will be high because of less action of other furnace. So kita akan dapat natriuresis, but the renal function and adrenal function is normal. SIADH is the diagnosis of exclusion. You need to exclude other causes of polyuria, polydipsia. So one of it is aldosterone, adrenal and renal function. Next is water depletion. So water yang kurang. Okay, water yang kurang can be caused by you reduce intake ataupun you increase excretion, increase loss daripada urine ataupun other extrarenal punya source. Okay, so decrease in intake most commonly in extreme ages, macam kanak-kanak. If let's say babies you tak bagi minum susu, dia akan dehydrated. Okay, ataupun elderly patients or patient who is unconscious. So you can also get it from increased loss. So increased loss ni ada dua jenis. You kena tengok whether the loss is actually the hypotonic fluids, maksudnya the free water je yang hilang, ataupun the isotonic fluid, water and electrolytes. Okay, because the clinical effects of these two are different. Kalau water only dia jadi lain, kalau water and electrolytes dia akan jadi lain. Okay, so in predominant water depletion ataupun hypotonic, dia keluar air sahaja. Okay, what happened during this time? Air keluar, so sirap tadi jadi makin pekat. ECF high is ECF or osmolality will be increased. So water will come out from the intracellular masuk ke intravascular space. ICF dia akan keluar lah kan. So this will stimulate the thirst center to increasekan thirst punya patient, and akan jadi thirsty, patient akan increase water intake. At the same time, this will stimulate vasopressin release, iaitu ADH lah. So ADH akan retain more water. Okay, but the key important is ada redistribution of water. So contohlah, you hilangkan 100% of water daripada the vascular space, but because you hilang pure water kan, so water daripada intracellular akan pergi masuk ke vascular space. So dia akan jadi you share the amount of volume loss to in between intra and extracellular compartment. So instead of you hilang 100, but actually bila you dah share dengan intracellular space, you hilang 50. Okay, so that is not so severe as compared to isotonic fluid loss. Okay, so what are the causes of hypotonic fluid loss? So you hilang daripada renal ataupun extrarenal. Okay, renal dalam urine lah. Okay, so causes are renal tubular disorders, diabetes insipidus, osmotic diuresis. Osmotic diuresis ni contoh macam diabetes mellitus ataupun patient on mannitol. So bila in diabetes mellitus, you have high sugar content, hyperglycemia, benda ni akan keluar ke dalam urine, glucose ni. But because of high solute dalam urine ni, urine cannot reabsorb water. So water akan keluar ke dalam urine. This is called osmotic diuresis. Okay, DI will be discussed later. From skin, sweating ataupun lung, hyperventilation. You sweat a lot, so you akan dapat pure water loss. Okay. And the effect is clinical effect, loss of water from ECF akan increasekan osmolality, but this will move water from ICF to ECF, thus stimulate thirst and vasopressin release. And signs of ECF volume reductions are not usually present in this hypotonic fluid loss, because the amount of the volume of loss just now is shared in between intracellular and extracellular space. And patient normally presented with thirsty, dryness of the mouth, difficulty of swallowing, weakness, confusion, and kita akan dapat signs of dehydration lah. For example, weight loss, dry mucous membrane, reduced saliva secretion, and reduced urine volume. So for lab investigation, in hypotonic fluid loss, you can get hyponatremia. Because air yang hilang kan, so dia akan jadi pekat serum kita. So plasma protein will be high, hematocrit will be high. Hematocrit ni is the RBC. Because water dah hilang, of course hematocrit will be concentrated, hemoconcentration. Urine osmolality will be high. Why? Because you lost water and your body try to reabsorb water untuk compensate for the loss. So, urine yang dikeluarkan adalah very concentrated. Okay? This is the homeostatic mechanism. Unless if your loss is through the kidney. Maksudnya, causes just now is from the kidney. So, you takkan dapatlah urine osmolarity ni concentrated. Okay? Next is isotonic fluid loss. In this, you hilang both the electrolytes as well as the sodium. So, when you lost both of sodium and water, dia tak ada pemegang untuk tarik water from the intracellular compartment. So, you hilang 100, tapi because of there is no osmotic changes, water takkan bergerak daripada intracellular ke extracellular. So, 100% tu akan keluar 100% daripada volume. So, patient akan dapat signs of shock. Dah belajar shock?
Dah.
Okay. So, you akan dapat reduced effective arterial blood volume. So, this akan stimulate all your punya shock punya mechanism. Stimulate the sympathetic activity, stimulate the vasoreceptors, stimulate the RAAS, and stimulate ADH. So, ADH keluar, aldosterone activated, baroreceptors activated. So, all of these are to restore back the volume. Okay. So, the causes are sama macam tadi, extrarenal or renal causes. So, for renal, it can be because of mineralocorticoid deficiency, diuretics, skin burns. Maksudnya bila burns, kita ada protective layer tu dah hilang. So, water boleh keluar as well as the electrolytes. Or GIT loss. Contoh macam diarrhea, vomiting. Bila you vomit, your vomitus tu also contain the acid, the sodium. Okay. So, you lost both water and electrolytes. So, kalau air sirap tadi hilang air sahaja. Now, you tumpahkan air sirap tu. Adakah concentration dia berbeza? Dia akan still sama. So, the sodium and water are both depleted. And there is no immediate changes in the concentration of sodium. Okay? No fluid movement from ICF to the ECF, as well as complication yang akan dapat shock punya complication because you lost water. Okay. So what are the signs and symptoms of shocks? Dah belajar kan? Reduce circulatory volume, so dia akan dapat hypotension, tachycardia, palpitation, kalau symptoms, syncope, weakness, postural dizziness, coma, these are all the symptoms. But the signs you can get, tachycardia, hypotension, circulatory failure, oliguria. Oliguria kenapa? Oliguria means less urine. So it happens because body try to compensate. Loss of fluid tu dia nak reabsorb balik, masuk ke dalam circulation. So you can get oliguria and reduced ketoacidosis. Yeah. So these are the summary of the effects of both fluid loss, isotonic and hypotonic. So in between these two, Serum sodium in hypotonic fluid loss will be more elevated lah as compared to isotonic fluid loss. Hematocrit will be slightly elevated in hypotonic but will be markedly elevated in isotonic fluid loss. ECF volume akan more reduced in isotonic fluid loss because there is no shared fluid daripada intracellular to extracellular space. Serum urea will be high, urine volume will be low. Thus, early and late manifestation and signs of shock to early in isotonic fluid loss. Late ni because dia lambat lah. If let's say you hilang lagi, continuously hilang, then daripada 100 tadi 50, you lost lagi another 100, lama-lama you akan dapat signs of vascular shock tu. Okay. So, in previous presentation, I dah sebut pasal DI. So, what is diabetes insipidus? This condition you often mistaken with SIADH. Nanti dalam exam tu tertukar-tukar lah. SIADH lah, DI lah. So, you remember SIADH, you have excess of ADH. You remember ADH is antidiuretic. Just now, SIADH is excess. Now, in DI, you have deficient. Tak ada ADH tu. Okay, tak ada ADH or the ADH cannot function properly. So, what happen bila ADH tak ada? You akan lost water. Akan dapat polyuria. Kenapa polyuria tu hypotonic? Because yang keluar tu is purely water. And compensatory polydipsia. Patient akan minum, tapi because ADH tu tak ada, macam minum and keluar. Minum and keluar. Dia tak retain dalam body. So the clinical presentation, patient will have polyuria, which is defined by urine output more than 3 liter over 24 hours dan polydipsia. Okay, polydipsia tu minum banyak lah. So we have two types of DI. Satu is cranial DI, satu is nephrogenic DI. So cranial DI is when there is a deficiency in ADH secretion ataupun production. Okay. So ADH ni dia being synthesis by the hypothalamus and is stored in the posterior pituitary kan. So any disorders yang kacau the brain akan mengganggu ADH punya secretion. For example, you have tumors kat area tu, craniopharyngioma ke, any tumor with suprasellar extension can cause because dia duduk dekat pituitary. Okay, any granulomatous disease, contoh TB lah kat dalam CNS, ataupun infection, meningitis, encephalitis, or any vascular disorders, or any trauma and surgery akan disrupt this ADH synthesis and secretion. Okay. The other one is nephrogenic DI. So kalau cranial just now is because of deficiency of ADH. In nephrogenic DI, kidney unable to respond to ADH secretion. ADH tu maybe ada, but because of the receptor tu tak nak pun respond to the ADH, so water still akan keluar. Okay, it can be because of familial, tiba-tiba ada mutation dekat receptor tu, atau any metabolic causes such as hypokalemia ataupun hypercalcemia, ataupun drugs, patient contohlah mood disorders, ada bipolar mood disorders on lithium. So this lithium can also affect the receptors. Post-obstructive uropathy ataupun any renal tubular disease itself. So kat tubular tu memang ada masalah, which you will learn in the kidney punya block. Okay, so in this condition, the ADH receptor is not functioning very well. Okay. Other differential, you need to also know that other causes can also cause polyuria. Polyuria tu maksudnya kencing banyak lah. So it can be because of diabetes ataupun psychogenic polydipsia. Yang you minum air banyak, keluar banyak. So the results is because you pass a lot of urine, so your 24-hour urine will be high, more than 3 liters. Serum sodium akan jadi very concentrated because you hilang air. Kalau air sirap tadi, hilang air is concentrated lah kan, pekatlah sirap tu. Serum osmolarity will be high. Serum. Okay, jangan tertukar dengan urine. Urine punya concentration will be low, diluted because air banyak keluar ke urine. So how do you confirm DI? Okay, so you try suruh patient jangan minum air for 24 hours. At the same time, you have to monitor. In patient with psychogenic polydipsia, maksudnya dia minum air banyak, kan? Dia akan kencing banyak. So, in that patient, bila kita suruh stop dia minum air, urine dia takkan banyak. But in DI, because DI tu tak ada, ADH tu tak ada, dia akan keep on keluar urine yang banyak. Urine tu akan maintain hypoosmolar walaupun dia dah stop minum air. Okay, how do you differentiate between cranial and nephrogenic? You bagi dia synthetic ADH ataupun nama lain dia DDAVP ataupun desmopressin. That is synthetic ADH. So do you think which one akan respond to this synthetic ADH? Cranial. Sebab cranial dia deficient. So you bagi ADH, you tiba-tiba nampak concentrated urine. Urine tu boleh jadi concentrated. But in nephrogenic DI, because of the receptor tu rosak, you bagilah ADH banyak pun, the urine will still be hypoosmolar. Okay? So boleh jawab So these are differences between DI and SIADH. One is excess, one is deficient. Which one has hyponatremia? DI ke SIADH? DI. Okay. Which one yang lagi pekat? Serum osmolarity tu lagi tinggi?
DI.
Which one yang akan menghasilkan diluted urine?
DI. DI.
Diluted urine.
DI.
Okay. So DI. So this is just the summary. Okay. Next kita masuk sodium. Okay. Habis dah water, now sodium. Sodium ni banyak dekat mana? Intracellular, extracellular. Extracellular. It is the major cation of the extracellular compartment. Okay. So the normal serum sodium is 135, 145. You don't have to remember. I will give this during the exam. Yang lain boleh baca Okay, so the imbalance you have hyper or hyponatremia. So hyponatremia is when the serum sodium is more than 145, meaning sodium tu banyak. Okay. So what are the causes of serum sodium banyak ni? It can be because of sodium tu sendiri banyak ataupun because of the water yang kurang. Sirap tu lebih ataupun air dia kurang. That is a cause. Dua tu. So excess sodium. Bila excess sodium? Bila excess sirap tu? Okay, you can get bila you ambil extra sodium whereby you bagi kat patient tu dalam ward hypertonic saline. You bagi extra sodium lah. Ataupun orang pergi minum air salt ataupun air garam ataupun air pantai lah, salt water injection. So and macam mana lagi sodium tu akan jadi increase bila you cannot excrete the sodium, and that is from the kidney problem. So in kidney, whereby in acute or chronic kidney disease, kidney unable to excrete the sodium. So sodium akan retain dalam body. The other thing is when there is increased tubular reabsorption. Tadi tak keluar, glomerular filtration, tak boleh nak keluar. Satu lagi, bila dah you keluar ke glomerulus, the tubule akan reabsorb, kan? Now tubule tu akan increase reabsorption. Okay, in cases of Cushing syndrome or Conn syndrome. Why? In these two conditions, you have excess aldosterone and cortisol. Cortisol is also have mineralocorticoid activity. So in these two, MR receptors being activated and sodium reabsorption can increase. So sodium akan retain dalam body. Okay. While in increased water loss, kita dah discuss dah banyak in previous punya section. Causes can be from the renal or from the extra-renal, such as sweating, burns, diarrhea. Okay. So what is the effect of hypernatremia? So water dia akan keluar daripada sel keluarkan. Sel tu akan shrink. Okay, sel tu sel otak lah. So hyponatremia akan increasekan ECF, hyperosmolarity. Water moves out of the intracellular compartment. Cellular akan dehydrated. And satu, you can have thirsty. Dua, mental confusion. Tiga, you can have cerebral hemorrhage. Okay. So now we move on to hyponatremia. Hyponatremia is when the serum sodium is less than 135. So it can be because of you lost sodium, sirap tu hilang, ataupun you have gained more water, you add in more water. Okay. So, and then you can classify this according to whether it is a sodium excess, hypovolemic hyponatremia, water excess, euvolemic hyponatremia, ataupun water and sodium excess. Apa maksud hypovolemic, euvolemic and hypovolemic? So you look at the volume status of the patient, whether patient ni overload ke tak. You nampak signs of peripheral edema, that is hypervolemic, the volume status. Euvolemic means macam kita, we tak ada signs of hypo ataupun hyper, you just normal. But in hypovolemic, you akan dapat signs of low volume. Patient akan dry mucous membrane, reduced skin turgor, dehydrated lah maksudnya. So these are the volemic, normal. This is hypovolemic, so the volume is low. Euvolemic sama, tapi you dapat hyponatremia. And hypovolemic is when you have excess volume. Okay. So the effect of hyponatremia, because outside ni low osmolarity, so water will move from outside into the cell. Cell akan dapat cellular swelling, cerebral edema. Okay. And the symptoms include nausea, vomiting, and cerebral edema tu dapat confusion, coma, increased intracranial pressure, and brain herniation. So what is hypovolemic hyponatremia? So in this case, you have severe sodium depletion. Sodium tu hilang. Tapi sodium dia takkan hilang sorang-sorang. Dia akan keluar dengan water. That is why dia dapat hypovolemia. Okay. And there is hypovolemic stimulus, increase ADH secretion, then water akan try to reabsorb. Okay. Causes include renal or extrarenal loss of sodium. Contoh, GIT, skin from burn, salt losing nephritis, ataupun Addison's disease. Addison ni adalah deficiency of mineral corticoid deficiency lah, because of lack of aldosterone. And then you have the clinical signs of hypovolemia, yang tachycardia semua tadi lah, yang dehydration. Okay. While in water excess ataupun euvolemic hyponatremia, dalam keadaan ini it causes dilutional hyponatremia with reduced plasma osmolarity. Maksudnya sodium tu sama je, tapi because of you add more water, sodium become diluted. Okay, causes dia kita dah discuss tadi, SIADH, psychogenic polydipsia, and hypothyroidism. Okay, thyroid hormone, what is the function of thyroid hormone? Increase basal metabolic rate lah kan. So bila in hypothyroidism, thyroid hormone akan low. So this will cause bradycardia, heart pump pumping slow. So cardiac output is measured by heart rate. Okay, so heart rate low, cardiac output akan jadi low. So this akan menyebabkan kita detected by the baroreceptors. Baroreceptors kata tak cukup volume. So apa yang jadi? ADH akan stimulated. Kita akan reabsorb more water. But adakah sodium kita berkurang tadi? No, because of others. Okay. So euvolemic. So next is hypervolemia. Okay. In hypervolemia, kita ada excess in volume. Okay, macam mana benda tu jadi? So first, in congestive cardiac failure, heart tu fail to pump to meet the oxygen demand kan. So what happen is dekat peripheral cells tu, bila pump tu tak jalan, dia akan jadi hypoperfusion, lack of blood flow. So kalau lack of blood flow lalu dekat renal, that will stimulate the RAAS. Okay, so water akan sodium will be reabsorbed. Sama juga dia stimulate ADH, and this will increase water reabsorption. Okay, in nephrotic syndrome ni ibarat you ambil penapis air tu, tapi penapis tu bocor. This is what happened to the glomerulus. Glomerulus tu bocor menyebabkan albumin can pass through. Bila albumin pass through, patient akan dapat hypoalbuminemia. Okay, bila hypoalbuminemia, water dalam intravascular space akan keluar because there is reduced oncotic pressure, akan keluar ke interstitial. So ultimately this akan menyebabkan reduce in effective circulating volume, which will also stimulate your ADH release. So water akan di reabsorb. Okay, but the volume tu akan bertambah lah. Water tadi keluar ke space and you reabsorb more water. And in liver cirrhosis, it is due to reduced albumin synthesis. So sama cerita macam nephrotic syndrome, albumin loss. In liver cirrhosis, albumin reduced synthesis. But ultimately, these two akan menyebabkan hypoalbuminemia and reduced oncotic pressure, dan water akan loss, reducing the circulatory volume. Okay. So, yeah. And other causes of hyponatremia adalah satu pseudo-hyponatremia. Pseudo ni maksudnya adalah false. So, it is a false hyponatremia in cases of severe hyperproteinemia and hyperlipidemia. So, yang ini analyzer akan baca as hyponatremia. Not because dia true hyponatremia, but because in plasma tu ada excess of lipid and protein. So, maksudnya, if let's say dalam air sirap tu, you tambah pula selasih. Okay, so bila you nak baca tu, you ambil fraction tu, you terkeluar tu, dia terambil sekali dengan benda tu, so dia tak boleh baca lah sodium tu sebagai normal. Dia akan baca as less, because dia ambil pun less. Okay. Next is hyperglycemia. So in hyperglycemia, dalam vascular space tu ada high glucose. In patient macam contoh diabetes mellitus lah. So high glucose ni dia akan exert the osmotic effect. Water akan keluar daripada intracellular masuk ke extracellular. Water akan draws out. But what happened to sodium? It will be diluted. Okay. But the osmolality will be high because of the presence of glucose. Glucose tu adalah the osmotic active particles. Okay. Next is potassium. Potassium is a major intracellular cation. So dia duduk banyak dalam intracellular. So the normal concentration is 3.5 to 5. So anything below 3.5 is hypokalemia. Anything above 5 is hyperkalemia. Okay. So hyperkalemia is when the serum potassium is more than 5. So causes can be due to macam mana potassium tu increase dalam badan. Satu, bila dia reduce excretion. You reduce excretion. Dua, apabila you increase makan, increase intake. Tiga, apabila you ada transcellular movement. You increasekan potassium keluar daripada intracellular into the extracellular space. Okay. In increase intake, you boleh goreng yang ni from IV drip, makan ataupun makan pisang banyak in CKD patient. In decrease excretion, you know kidney ada problem, tak nak excrete. So in AKI ataupun in CKD, patient can get hyperkalemia. Or drugs such as ACE, potassium sparing ataupun NSAID akan menyebabkan reduced potassium excretion. Macam mana nanti saya tunjuk gambar. And next in transcellular movement, whereby in acidosis ataupun in insulin deficiency, potassium akan keluar daripada sel keluar. Okay, you know that in insulin deficiency, insulin tu digunakan untuk glucose entry into the cell. Glucose masuk sekali dengan sodium kena masuk. Tapi kalau dia deficiency, sodium tak boleh nak masuk. So apa yang jadi? Potassium yang keluar. Okay. And in massive tissue necrosis, maksudnya tiba-tiba you have massive tumor lysis, you bagi patient on chemo drugs. So tumor cells pecah. So benda ni is in intracellular. Potassium banyak in intracellular. So bila dia pecah, dia akan release all this intracellular content, raising the plasma potassium. Okay, so this is gambar yang dekat renal tubule. As you can see, this is the mineralocorticoid receptors. Aldosterone akan duduk kat sini. So what is the function? Is to increasekan synthesis of INAC and ROMK untuk sodium reabsorption, potassium excretion into urine. Okay, so bila you have deficiency of aldosterone ataupun you have ACE inhibitor or ARB, sodium tadi okay, sodium tak boleh nak reabsorb and potassium tak boleh nak keluar. So potassium akan retain dalam badan, jadi hyperkalemia. Okay. Next is the potassium cellular shift, which akan affected by acidosis, hyperglycemia, insulin, beta-2 agonist. So any case yang menyebabkan this condition akan associated dengan hyperkalemia. Okay, so potassium banyak bergerak keluar. And these are causes of pseudo hyperkalemia. Pseudo macam hyponatremia tadi, pseudo hyperkalemia occurs when you dapat bacaan high potassium but it's actually not a true high potassium. So macam mana dia jadi? Bila you draw patient blood keluar, that blood tu lies pecah. But dia bukan pecah kat dalam, dia pecah kat luar. In vivo, maksudnya dalam tube cells. So you dapat hyperkalemia. But that is not a true hyperkalemia. Ataupun IV drip contamination, you ambil daripada drip site. Kat drip site tu pula kita bagi potassium. So contamination for the potassium. Ataupun patient sendiri ada abnormal blood cell, leukocytosis ataupun thrombocytosis. This platelet and leukocyte, bila dia abnormal, meaning maksudnya dalam leukemia ke, dia tak stabil tau, and dia senang nak pecah. Bila dia pecah, dia akan release the intracellular content. So the effect, it is very dangerous. Why? Because it lowers the resting membrane potential, shorten cardiac action potential, and increases the speed of repolarization. So tak ingat kan fisiologi kan? But whatever it is, it can cause excitability of the cell. Muscle cell ke, skeletal muscle ke. So muscle akan, the cardiac muscle akan tergedi-gedi gitu. So dia akan jadi ventricular tachycardia, ventricular tachyarrhythmia. On ECG, you can get tall tensor T wave, absence of P wave, and widening of QRS complex. Okay, yang ni lah. Sebelum lama-lama dia akan lagi broad gitu, akan jadi ventricular fibrillation. Okay, skeletal muscle akan jadi hyperactive muscle, paresthesia, and lama-lama because of you lost ATP, because of increase in hyperactive muscle ni, patient akan dapat muscle weakness and flaccid paralysis. Next is hypokalemia. Okay, tadi hyperkalemia. Hypokalemia is when you kurang makan ataupun you increase excretion to the kidney, ataupun you akan increasekan potassium masuk ke dalam sel. Tadi potassium keluar, now potassium masuk dalam sel. Transcellular movement of potassium. So insufficient intake in, you bagi parenteral infusion, you tak bagi potassium, you bagi air sahaja dengan saline. So you dapat dilution, dapat hypokalemia. Excess excretion maksudnya in renal loss of potassium. In cases of mineralocorticoid excess, you have excess in aldosterone. Aldosterone fungsinya untuk reabsorb sodium. In reabsorption of sodium, you akan excrete the potassium. In drugs, extrarenal loss such as vomiting, diarrhea, and intracellular movement. Okay, compared to just now, insulin deficiency. Now bila kita bagi insulin kat patient, so tiba-tiba dia akan menyebabkan potassium masuk ke dalam sel lah. Beta adrenergic agonist, alkalosis, and refeeding syndrome. Refeeding syndrome ni sama reason macam you bagi insulin. You tak makan lama, tiba-tiba you bagi glucose, you masukkan makanan. Of course, this will stimulate insulin release. Bila insulin akan jadi excess, this will increases the glucose entry into the cell as well as the potassium. Okay. So you akan dapat hypokalemia. So the effect, you akan dapat hypokalemia enhances the potassium efflux from the cell, and cell akan jadi hyperpolarized, and this thus difficult to initiate another action potential. So dia akan jadi slower nerve conduction, slow aja. So patient akan dapat ECG changes pun ST depression, T wave inversion, prominent U wave. Maksudnya lepas T tu ada U. U tu prominent. Prolonged PR interval, and patient can also ada muscle weakness. Weakness, constipation because of GI muscle tu dah weak, so dapat constipation, hypotonia, tone pun jadi sloppy, confusion, and we know because hypokalemia just now can cause polyuria, so there is increasing impact concentration ability leading to polyuria. Okay. And you can get metabolic alkalosis, skeletal muscle weakness, and you dapat glucose intolerance because hypoki akan inhibit insulin release. Okay, I think this is the last slide kot. Okay, any question?